the main objective of the course is optimizing outcomes in complex cataract surgeries. So we had a good list of speakers, but unfortunately a couple of them could not make it. So I think I will go first and talking about managing white cataracts, and then we'll have Dr. Srinivas G. Rao, who's going to talk about cataract surgery and clouded corneas. So there is a connection between cornea and cataracts too. NIVEAN video.
At the outset, let me thank NIVEAN and AIOC for this wonderful opportunity of
So you all know that white cataracts is a challenge for all cataract surgeons. So I'm just going to share a couple of tricks on managing different types of white cataracts. So the first case I'm going to show is a white cataract, which is an intumescent cataract. So for every white cataract, I think Stefan blue staining is a key important factor so that you can visualize the anterior capsule well. And this is one of the techniques I always prefer is the fine needle aspiration, where you just poke the needle in the center and start aspirating. So once you aspirate, you can see the liquefied cortex that is getting aspirated. So once a little bit of that is done, now the pressure is decreased. So then again put viscoelastic, and then the anterior capsule will be flat. So the second trick is, after you get that shape, that L shape, make sure the flap is always parallel to the anterior capsule. So this avoids the runaway of the rhexis. Only when this flap lifts up, so that time the force tries to pull it towards the tunnel. So that is when it tries to extend. And most commonly the subincisional area is where the rhexis extends. So always come out, put in viscoelastic, and then restart doing the rhexis. And people who do through the main incision, sometimes you see near the main incision only it tries to run away. So ideally a 4 or a 4.5 to a 5 millimeter rhexis is ideal for any cataract surgery. So rhexis, people who are comfortable, as you can see here, another scenario where it's just going to run away. So I stop, put in viscoelastic, use a cystitome here, but this time I'm going to use the force towards the center. So it comes inside. So this also how you bring the runaway rhexis within the margin. You can also use the forceps, because the forceps also, some people are more comfortable with the forceps. So grasp it nicely and then pull it towards the center. So it can either be done with the cystitome or with the rhexis forceps, whichever the surgeon is comfortable with. So after the rhexis, moving on to the phaco part. So this is a technique which I do called the burr hole technique, where the superior portion of the cataract slight trenching is done. So this helps to get nice hold inside the center of the nucleus, slightly lift it and then initiate the chopping. Instead of going directly, doing this burr helps our probe to go slightly deeper, and also some amount of the central epinucleus is also removed. Then once the piece is cracked, once one segment is there, I always prefer to remove it in these types of hard cataracts or mature cataracts, because then you can have some space when you remove the nucleus and also see what is happening better. And we all know in these types of cataracts, there won't be any cortex. If at all there is cortex, there will be only peripheral cortex and some sticky cortex, which can also be removed after the lens is also been implanted. So I usually prefer to implant the lens through the irrigation here, but the only thing that is important is the wound should be stable. There should not be any leakage to the side port, because that can lead to the collapse and then PC rupture. So under irrigation, we're just placing the lens, and you can see if you have a good rhexis, a good overlap of the IOL, this prevents the PCO formation also. So moving on to the next cataract of white is, you see it is white, but if you can see underneath it, there is this brown segment that is showing. So you know these are slightly harder cataracts where this technique is not going to work, where you're trying to aspirate the fluid. So then going, and you can see the moving mobile nucleus underneath it. So here again, getting the rhexis is very important, because in these cases, if at all you have a rupture, you can also keep the lens in the sulcus or do a capture. So slightly smaller rhexis, as you can see here, compared to the other cases. And then slightly, see, it was actually looking white, but it's actually a brown cataract underneath. So these are slightly challenging. See, you can see the full crack is not happened there. This epinucleus plate is still not cracked. But sometimes instead of doing the same place, I try to move around and try and do the same procedure again. So till we crack the epinucleus plate, we should not try removing the pieces. See, this one has gone a slightly deeper crack. and still going down and separating. So once you have that pie there which is separated, and then you remove the piece and bring it to the anterior chamber. Otherwise what happens is half the nucleus tries to come out, and that puts more stress on the zonules. Then you'll have a zonular dialysis, or the whole bag gets dislocated. And this is how the surgery ended. So the next type of white cataracts, the myth is only direct chop can be done. No, it is not true. You can do even stop and chop technique, or whatever technique you are comfortable with. Here also you see it looks white, but then after you removed it, underneath is a brown black cataract there, more harder than the previous ones, and with some amount of calcification. So here I am doing the normal stop and chop. So doing the trench, but only thing modification is I'm not completing the trench till the end. So there you can hold it and crack. So now you have very less portion of the nucleus to crack, and the center already, because you have done the trenching, the split happens more easily. So this is for me something what I call as like a modified stop and chop. So I'm combining both the trenching and the chopping. So once you see that line and that crack has come, then again it just behaves like any other normal cataract case. But these cases, make sure we use little more of phaco power also, because these are hard nucleus. Otherwise we'll be spending too much of time, and that causes corneal edema. So there has to be good amount of titration of the power. And as I've already told you, these cases don't have much of a cortex. This is just like a calcified thing which will later on become the Sommering ring. So it is better to remove it if you see it on table. Sometimes you have to do phaco 3 to remove these Sommering rings. And this is how the case ended. You can see clear corneas. So last type of cataract will be the hypermature cataract, where you see this leaking proteinaceous material which is caused phacolytic glaucoma. So with the mid-dilated pupil, as you can see, as soon as you open it up, you see the milky liquefied cortex coming out. And these types of cases have very small nucleus underneath. They don't have a large nucleus. So here you can see I'm using the rhexis forceps to make the rhexis. So once the rhexis is done, here again trying to go for a slightly smaller rhexis. So the new technique here is I'm going to do an IOL scaffold technique. So that is applicable only for the small nucleus, where you inject the lens first into the bag. As you can see here, make sure it is visible correctly. As you can see, the lens going underneath the nucleus, and then dialing it into the bag. And now the chopping is initiated, and this time the chopping has to be into the center. So this is a mid-dilated pupil, so don't go to the periphery, just do the chopping in the center. And once the separation has happened, you can just bring it up slightly, making sure you protect the endothelium, at the same time making sure you are not too close to the IOL. So in these types of small hypermature cataract, this is scaffold technique is very useful, because this lens which is there helps you protect from having any PC rupture. As you can see, the lens well placed into the bag. Some of them initially used to do it in the anterior chamber, but if you do it in the anterior chamber, it crowds the anterior chamber. So this is a better technique. So thank you once again. So any questions or suggestions, Aisha?
So I have a question, Dr. Naveen. Excellent videos. In this hard or black cataract, or this one, because my next topic is cornea. How do you protect cornea?
I just deliberately I come out in between the phaco and use viscoelastic. I don't use the Schaftel technique much practically, even though that is an ideal technique. And when you do that, they say the corneas are much clearer, or viscoat, because that is a combination, that is the easiest method. The basic thing is correct amount of energy. If it is too less, you're going to do phaco for a long time. If it is too high, it will cause wound burn. So that is why if you can see in my videos, we didn't have wound burn. So getting the right power, 50 to 60 power, not too much, not wasting energy. At the same time, at least once or twice, you come out and fill it with viscoelastic.
Another question I want to ask is all this hypermature cataract where the nucleus keeps
moving.
You are very particular about any particular lens to use in these cases, or any lens is okay?
Any lens is fine. Actually, what I used here is hydrophilic, but if you are using hydrophobic, it is better because the haptics are longer. So basic idea is to go keep the bag stretched, because initially we had cases where you are completing the case, at the last time the bag will roll and come. Most of the time hypermature everything, and then only the last stage because the eyeball collapses. So this lens inside the bag just stretches the bag. So bag is stretched, so that time nothing gets caught, and we know that cortex is not going to be there. If at all it is going to be there, it is going to be only in the periphery, which we can actually even leave, because that helps in fibrosis, so that it just keeps the lens in place. So next we'll have Dr. Srinivasan, who's the Chief Medical Officer of Agarwal Tambaram branch, on talking about how do you manage when you have a double trouble like combining cataract and corneal problems.
Yes, Rao. No, not that. Below one. Yes, Rao. Yeah. That machine made simple.
None of the producers have any financial interest in any of the products or procedures mentioned or shown in this film. No copyright infringement intended for the music used in the video. If you have a blurred image during surgery, what would you do?
Rub my eyes to have a clearer vision.
I will ask my assistant to probably clean the microscope lenses.
Change the microscope bulb.
I would dim the OR lights.
I would probably scrape the cornea.
I would refer to an expert surgeon.
Endo Illuminator, machine made simple. The surgical approach in eyes with poor visualization is highly challenging. When visualization of intraocular structures seems inadequate under the operating microscope, a simple modification in the surgical procedure by having an endo illuminator can be the game changer. Endo illuminator works on the principle of oblique illumination, wherein the eye is directly seen under the microscope with the light of the microscope switched off and the endo illuminator being held at an angle of more than 70 degrees externally along the limbus to illuminate the anterior segment structures. It improves visualization by providing a stable, stationary, and diffused form of illumination. The illumination is based on a wide-angle approach resulting in low irradiance. Intracameral endo-illumination reduces the light scatter and glare, maximizing corneal transparency and allowing safe and effective surgery. Since 1993, use of endo-illuminator has been described for cataract surgery for visualizing the anterior capsular flap in hypermature cataracts. Endo-illumination guided irrigation and aspiration during combined 23-gauge sutureless vitrectomy, as well as endo-illuminated infusion cannula for bimanual anterior chamber vitrectomy has also been described. Handheld fibers exhibit smaller illumination angles. However, they are more focused. Current illumination systems consist of high-intensity light sources and single-use endo-illumination fibers up to 30G. Existing devices employ xenon, halogen, mercury vapor lamps, or light-emitting diodes, LEDs, as light sources. Commercial systems available from Synergetics, Alcon Laboratories, or DORC. Use of endo-illuminator is described sparingly in anterior segment surgeries. During anterior segment surgeries complicated by hazy media, endo-illuminator acts as an external light source, enhancing visibility of the operating surgeon, aiding in smooth performance, achieving better surgical outcome. Here, we describe a series of challenging surgical scenarios in which the technique of endo-illuminator assisted surgery was performed with ease. The first case is of scarred cornea, in which visualization of the anterior chamber and beyond was arduous. Even after debriding the epithelium, coaxial light of the microscope doesn't help much in visualization. This is where the endo-illuminator comes to the rescue. It helps to visualize and implant a glued IOL. The next scenario is that of a post-traumatic cataract with iridodialysis. The endo-illuminator helps us in visualization of the remnant iris while we use the piecemeal technique in different areas to refix the iridodialysis. It also aids in better visualization of the vitreous strands when dye is not used. Furthermore, it helps while passing the 9-0 needle through the iris during single-pass 4-throw pupilloplasty and cutting of sutures post-SFT. In the next case scenario of a failed PK graft, the role of endo-illuminator is substantial as the opaque failed graft doesn't allow any coaxial light of the microscope to pass through, and endo-illuminator helps in visualizing structures underneath. The endo-illuminator also aids in the formation of Purkinje images, which guides the centration of the pupil post-pinhole pupilloplasty using the single-pass fourth-row technique. In this interesting case of an ACIOL with summering ring in which the haptics were stuck in the anterior chamber angles, endo-illuminator assists in visualization and creating surgical iridectomy to release the haptic, and also while burping out the summering ring out of the AC and vitrectomy. In this case of glued IOL, where the haptic of 3-piece IOL broke, endo-illuminator comes to the rescue and helps in finding the broken end of haptic and safely explanting the haptic and damaged 3-piece IOL out of the eye. The view of the P-deck graft is enhanced when the endo-illuminator light is added to the field. When we put off the microscope light and just use the endo-illuminator light at an oblique angle, it gives beautiful illumination and excellent depth perception. The comprehension by the surgeon of the graft orientation and the graft dynamics within the anterior chamber is much better, and the direction of the graft can be easily made out. The unfolding of the graft can also be carried out with just the end illuminator light alone, and this gives a very good clarity to the surgeon, as you can see here, as opposed to the microscope light, where it is very difficult to make out whether the graft is facing upwards or downwards. You can see here the visualization is improved as compared to a very poor understanding of the graft with the microscope light alone. In case of inadvertent trauma to the Descemet's membrane, it can cause Descemet's membrane detachment, which might be very small and can get unnoticed, causing long-term corneal edema. Endo-illuminator light, when falls at an angle, can help in the visualization of these small breaks in DM. Vitrectomy endo-illumination attachments are often available, which allow aspiration infusion and vitrectomy. Apart from the above scenarios, it can be used in cases of trauma, chronic degenerative changes such as Labrador keratopathy, bullous keratopathy, corneal dystrophies, PPP, glued IOL, surgical iridotomy. Endothelial contact should be carefully avoided throughout and positioned inferotemporally and supported by the assistant. The endo-illumination probe should not physically interfere with microsurgical manipulation within the AC. The endo-illuminator aided modified approach to such cases is highly feasible, practical, and convenient. It can serve as a smart addition to our surgical armamentarium, as patients with concomitant pathology can still get good post-operative vision with this modified technique, helping achieve better results both intra and post-operatively.
Can I open the other one? Other one. One more video. It's a short video. I'll just...
None of the producers have any financial interest in the products or procedures shown.
See, in this kind of cases where the cornea is affected and things like that, where the anterior segment deficit, how thin it is, and or in a case of a penetrating keratoplasty, failed graft with cataracts, and the corneal vascularization is there. So it's going to be very difficult to do the surgery in this. In this also, we like to utilize the endo-illuminator thing. So even after scraping the epithelium, slight visualization is better. Then here, remember, whenever you're thinking of a bad cornea, always remember to plan. There can be, if it is a other side opacity, you can rotate the nucleus and bring where the visualization is there. Or you can go do a viscoat method, where I put a small little bit visco and carboxymethyl and then coat it with the viscoat. Even the viscoat don't give me anything, but still I say I'd prefer to use that. It's like a sandwich technique, and don't overfill always. Remember, when you are not visualizing, without realizing, we try to overfill the anterior chamber. That also can be done. Here, with the help of an endo-illuminator, we are able to see where the cataract is. Always switch off the microscope. That is very essential. Or make it very dim. And then you can use an endo-illuminator and see the visualization is much better. And protecting the cornea is also important. And in this case, in case you feel so, reduce the phaco energy and increase the flow rate and the vacuum in case you're finishing the surgery fast, or reduce the flow rate also, go with the slow surgery also. So here the cortical aspiration is also done, and the visualization is very poor in all these situations. And remember, always never overfill in case of a bad cornea cases. Minimal visco using in the anterior chamber is very essential, because when we always will be tense when we are not visualizing, we will always tend to overfill the thing. That will also make the cornea more cloudy. It will be slightly like not very tight eye. In that way, it's much better to perform the surgery. The other things are same, like single pass 4-throw pupilloplasty, performing in the same case. And remember, use the instead of the normal thing, you can use always the BSS saline. That is also very essential. The BSS saline of the Alcon BSS saline is much better. In this, we also charge the patient separately and tell them that they require this Viscoat and BSS. We have to explain to them why they are charged extra, and we have to tell them that it's very essential to protect their endothelium. Same case, we have done the single pass 4-throw pupilloplasty also in this patient. Same other things, like we finished it with the PDAC graft, because as you see the cornea is bad. I would like to thank especially Dr. NIVEAN for giving me this opportunity in AIOS. My only talk in AIOS. Thanks a lot. And I would like to thank Dr. Aisha and the other doctor, the two audience. At least we are happy. Otherwise, we are telling that we both will be staring each other. Thanks a lot, and thanks a lot for the audio visual and other team members also. Thank you. Yes, sir, we use that for normal cases also. And we switch it off. We switch it off. Otherwise, what happens is you will have too much glare. We always switch it off. And even in case where you don't find the rhexis is not great, like black cataract, we are using it for endoilluminator for this fighting the rhexis. Even after staining trypan blue, sometimes you may not say where the edge is, because the edge goes off in these cases. We use endoilluminator, it works well. Even the newer adapter microscope which has come, I don't know the name, like for 2.5 lakhs it comes. They attach with the microscope. Those also works better. Yeah. And the endoilluminator gives a much better than that. What I have seen is in those also the visualization is much better. This gives a much better thing. If no questions, thank you.
Thank you. My name is NIVEAN. First of all,
at the outset, let me thank NIVEAN and AIOS for this wonderful opportunity of presenting this very important topic, flags in complex situations. These are my financial interests. As you all know, flags has become a very, very important tool for all of us. Apart from the regular cataracts, I feel that flags is something which you can use for white cataracts, hard brown cataracts, posterior polar cataracts, subluxated cataracts, patients who got fuchs endothelial dystrophy, neither here nor there cataracts, that is called NHNT, shallow AC. You know how the artificial intelligence is becoming very popular in diabetic retinopathy and glaucoma detection. Can a computer perform better than a human brain? Obviously, the computer can do better than a human hand, I would say. There are many machines in the market which are available, Catalyst, the LensX, the LensAR, the Victus, and also the Zemer. I'm using the Catalyst system. I don't have any financial interest. But how do you compare flags with the manual phaco? The manual phaco is like Sachin Tendulkar. He is good only in one format. Where flags is a very versatile technology. Like Mahendra Singh Dhoni, he can play T20, he can play one-day international, he can do a very good test match as well. So that is the versatility of this technique which I want to drive home. It's a very in this topic. And what are the other advantages of flags? incision, the main port, the side port, LRI, the perfect rhexis, nucleus liquefaction, complex situations like white cataract, as I told you, brown cataract, PPC. The safety of the femto cattle is something which is phenomenal. The precision is something which is incredible. The accuracy is also excellent. The predictability is also very, very good in this machine, and faster recovery, and of course, a bladeless technology which you can market for your patients as well. What is the problem with the hard brown cataracts? The cataracts is very difficult to crack the nucleus because of the leathery attachments. Thin posterior capsules, increased incidence of corneal edema, and post-op corneal decompensation. You need to combine the technology with the technique. The technology is available to you. You see a brown cataract like this, it's like a piece of granite. You have do a conventional manual phaco, you can end up in a cornea like this. And if you do a femto, you can get a crystal clear cornea, mainly because of the amount of energy which is very, very less spent on this in these eyes in the anterior chamber, phaco energy. The fragmentation settings in hard cataracts with vertical spacing 25, the horizontal spacing 10, with the segmental soft, the spacing is about 200 micron. Pulse energy is about 8 or 10 millijoules. Just to show you how in a grade 3-4 cataract. So the advantage of the flax is that already the rhexis is there, which is about 5 or 5.1 millimeter, whatever size you want. And then you can see here, I'm the pre-chop of the nucleus is also there. I'm just separating the nucleus or the posterior nuclear plate using only a Sinski hook. I'm not using a sharp chopper or even a regular chopper for that matter. And you can see how the posterior nuclear plate completely separates. That is the biggest advantage of this flax technology. And the very fact that the gas bubbles are coming from there, you can see the rest of the cataract is like a child's play for you. And now then you inject viscode into the anterior chamber. Just to show you, there's another patient who's got a hard brown cataract, grade 4, grade 5. I've made the main incision with the flax machine and also the side port incisions as well. You can see the cataracta rubra, which is very, very typically of these cataracts. And you can see how the rhexis is already done. You can see the fragmentation of the nucleus, the softening of the nucleus also, which makes your life easy in this hard brown cataracts. So that is the biggest advantage in a flax technology. You can see here I'm just going and burying, there's no trenching required, and I'm opening up the posterior nuclear plate because it's already well separated. I need to go in the crevices or in the areas which are already chopped and are cut by the flax, by the femto laser. You can see how beautifully it is opening up and very nicely it's opened up. And you don't have to use much phaco energy at all. Combine this with the cold phaco technology, which is available in all the machines now, whether you use Ozil or the longitudinal phaco or the White Star, doesn't matter, but it makes your life easy. You can see this is a black cataract, just to show you how I'm just doing a trenching in a manual phaco. The amount of phaco energy which is delivered. Again, the black cataract, I'm using a flax again, rhexis, which is already done for you. You can make the rhexis a little larger also, depending on whatever you want. In this case, you can see here, I'm just chopping that cataract into smaller pieces, and see how beautifully it is opening up the posterior nuclear plate, and the gas bubbles are coming from the posterior side, which means that the cut has gone, the femto laser cut has gone all the way into the posterior nuclear plate. And that is the biggest advantage. You can see here consistently, you can deliver clear corneas and pristine wounds in all these brown cataracts. And this is one of the biggest advantages. The second advantage is patient with the corneal guttata. If you have sick cornea, and especially a hard brown cataract, like this case, you can see here this is a sick cornea, corneal guttata, and the endothelial cell count is probably less than 1,000. You can see it on the specular microscopy, and how beautifully I'm able to do the rhexis easily because of the flax with the femto, and also the pre-chopped cataract is also there. And that is one of the biggest advantage because I'm using less phaco energy, and the whole thing is over in a jiffy, and I don't have to spend much time. I don't have to spend much phaco energy. less heat build up in the anterior chamber or in the posterior chamber as well, for that matter. And you can see the post-operative, despite this the cornea being a sick cornea, you can see how the cornea is clear beautifully. Post-op 7 days, crystal clear cornea as well. Just to show you a patient who's got a subluxated cataract. You can see this is a subluxated cataract, and because of the shuttlecock injury. The biggest advantage of a shuttlecock of the subluxated cataract, because problem with the subluxated cataract is doing a rhexis, because there's no peripheral resistance. In a flax, if you see, I did a flax for this patient. You can see the rhexis is already done. You can see the cuts. So you don't underestimate the versatility of this flax machine. In a mature cataract, as long as the OCT recognizes, you can go and you can see here how beautifully the cut. So one of the biggest advantages of this thing is the subluxated cataracts. You can see a small pupil. Also, the flax is very good because it cuts beyond the rhexis margin. Not very small, less than 5 millimeter. I don't do normally flax, but around 5.5 or 6 millimeter, because my rhexis size will be around 4.5 or a little more than that. The advantage is because the rhexis is there, the cutting of the pre-chop is there, softening of the nucleus is there, and it cuts beyond the margin of the rhexis as well. In hard cataracts, reduce surgical time, reduce effective phaco time, more precision, clear corneas. Just to show you that in a white cataract also, the flax penetrates. You can see here the penetration of white cataract. You can see how beautifully penetrates. In this patient, I'm doing a multifocal or a toric lens in this particular patient. How beautifully the rhexis. The only thing is, look for skip areas in a patient who's got a very mature cataract. And an intumescent cataract, like the type of an intumescent cataract, Argentina flax sign, is a very common problem. It can be a serious problem. You can see that this is a foolproof method. If you do the flax in these patients, 100% of the time, or even 200% of the time, you can see that the Argentina flax sign doesn't occur. Only thing is, look for skip areas, and sometimes there can be a small, joints there. You need to make sure that you do a small rhexis there. Many times it's a free-floating rhexis as well. Again, posterior polar cataract, this is a go-to technology as far as I'm concerned, because the advantage of the intraoperative control is much better. And you can just see at the angle with the posterior polar cataract, I'm able to do that, and I am able to remove the, of course, it's a very soft cataract as well. And you need to follow all the protocols in a posterior polar cataract. And that is the biggest advantage. You can see a plaque on the posterior capsule. I'm doing a plaquectomy as well. Again, another patient with a posterior polar cataract. How I'm able to do the rhexis, everything, the rhexis size, whatever size you want, can go in and just pick up this nucleus. You don't have to rotate the nucleus. Rotation, as you know, is avoided in a posterior polar cataract. And the intraoperative control is very good. And I also have an offset. Normally, I have an offset in the posterior capsule of 500 microns for regular cataract, posterior polar. I shift it up a little bit. I keep it around 900 microns. Again, these are the cataracts which are neither here nor there, in between cataracts. Flax is probably the best because advantage is that rhexis is there and cutting of the nucleus is there, because these are cataracts very difficult to crack, very difficult to suck, very difficult to chop as well. And these are the neither here nor there cataract or NHLT cataracts, wherein the flax is probably the best way to go. And the take-home message is flax in complex situations, white bone cataracts, hard bone cataracts, posterior polar cataracts, subluxated cataracts, sweep endothelial dystrophy, NHLT cataracts, safety, precision, bladeless, consistency, wow effect, good platform for marketing, differentiates your practice. Thank you again, AIOS, for the wonderful opportunity.
Thank you. I think we have come to the end. So welcome. I think we had our presentations. Anything else you want to ask or anything? We can have a discussion. Done. Okay, thank you. So we're just closing the session now.